Hello.
Yes, Senashish, can you
Yes,
hear
sir.
us?
Yes, sir. Yes, I can hear
Yeah,
you.
okay.
No.
Sorry. Good morning. Today we'll have a discussion on a bilateral hernia with a patient in a having some prostatic symptoms. So, Dr. Snehashish Shah, who is a third-year Guinea resident at IPJ will present the case, and Professor Shudev Shah, Professor and Head of Surgery, NRS Medical College, will moderate this session. Dr. Shah, you please share the session, share your screen and present. Wait at the end of history, and then you'll discuss the examination.
Sure, sir. Sir, I'm sharing my screen, sir.
Yes.
Yes.
Good morning, respected teachers, Professor Dr. M.L. Shah, sir, and Professor Dr. Shudev Shah, sir, and my fellow colleagues. I'm Dr. Snehashish Shah, JR2 MS PGT of IPGML and SSKM Hospital, and I'll be presenting this case of bilateral inguinal hernia with features of prostatism. My patient, Dr. Deepankar Ghosh. My patient, Mr. Deepankar Ghosh, a 65 years aged male patient, Hindu, and currently unemployed, a resident of Krishnanagar, was admitted on 25th of May and is being examined today on 28th of May. Patient has a chief complaint of swelling in the right groin for 4 months and swelling in the left groin for 3 months. Patient also complains of swelling, of pain over the swellings on either side for 1 month. The patient was apparently well 4 months back when he started noticing a small swelling in the right groin, which appeared spontaneously. Insidious in onset, gradually progressive, was initially small in size and progressed to its present size of 5 into 5 centimeter. The swelling reduces on lying down and reappears again on standing, walking, and cupping. The patient complains of a similar swelling in the left groin for 3 months, which also appeared spontaneously, was insidious in onset, and gradually progressed to its present size of 3 into 3 centimeter. The swelling reduces on lying down and reappears again on standing, walking, and coughing. Patient also complains of pain over both the swellings occasionally for the last 1 month. The pain is dull aching in nature, has no radiation. The pain is relieved as the size of the swelling reduces on lying down and increases again on walking, standing, and straining. The patient gives a history of work involving heavy weight lifting for the last 30 years. There is no history of chronic constipation. Patient was a known smoker for the past 30 years, now stopped for the past 2 years. There is no history of long-standing cough or COPD. There is history of nocturia, hesitancy, and increased frequency of urine. However, there is no history of any acute urinary retention or urgency. There is no history of period of irreducibility or severe pain associated with vomiting and obstipation. In past history, there is no any history of any previous surgery or any medical illness. Now, coming to personal history, the patient is married and has 3 children, is on a mixed Indian diet, smoker for 30 years, now stopped for last 2 years, non-alcoholic. There is increased frequency of urine, nocturia, and hesitancy, and in bladder habits, and there is no history of any chronic constipation. Sleep appetite is normal, and patient belongs to poor economic status. And there is no significant family history and no significant treatment history. Patient has no known allergies. Now coming to the summary of the history, a 65 years old male patient presented with bilateral groin swelling for 3 to 4 months, which appeared spontaneously, was insidious in onset, gradually increased to its present size. The swellings reduce on lying down and reappear again on standing, walking, and straining. Patient also gives history of occasional pain over the swellings, which is dull aching in nature, increases on standing, and reduces on lying down. Patient gives a history of work involving heavy weight lifting as an occupational history and history of lower urinary tract symptoms of nocturia, increased frequency, and hesitancy of urine. No history of constipation, period of irreducibility, severe pain associated with vomiting and obstipation.
Okay.
Oh. So, can you give us your provisional diagnosis in this case?
Based on the history.
Yeah.
Sir, in the history, the patient complains of a swelling which is gradually.
Give the diagnosis. Justify later. Give the diagnosis.
So in this case, the diagnosis as per the history is a case of bilateral groin hernia in a patient in a 65-year-old male gentleman with features of lower urinary tract symptoms.
Fine. But you have said groin hernia. That means you have not pinpointed whether it's an inguinal hernia or a femoral hernia.
Yes, sir.
From the history, can we do that?
Sir, we can do, sir. The patient if it is an inguinal hernia, then the swelling will be
That is, they are examination findings. But I'm telling you that from the history, because this, as you said, is a male patient, 65 years of age.
yes, sir.
And so obviously there is no reason why you can't say that it is a bilateral inguinal hernia. This much we can obviously say, because femoral hernias are very rare in men.
Okay, sir.
So, and it is bilateral in position, so that is the most commonest to come. So of course we'll confirm by examination. So I think we can say that it is this patient is suffering from bilateral inguinal hernia.
Yes, sir.
Okay.
Yes, sir.
Fine. Proceed.
Regarding the history of smoking, you see, patient having a hernia and waiting for hernia surgery, smoking history is important. How does the smoking affects the outcome in hernia patient?
Sir, smoking will lead to decreased lung compliance and may increase cough, which can
That
cause
is one part.
recurrence of
That is
hernia.
one part. Patient of having smoking may have COPD, you mean, may have
Yes,
chronic
yes.
cough. That is one.
Yes.
What else? How does the smoking affects outcome of patient who is undergoing hernia surgery? There are a lot of things being discussed in smoking.
The tissue
Sir,
part of the thing.
sir,
Yeah.
So it may prevent in wound healing.
How it impairs wound healing and subsequent long-term outcome also is some smoking dependent factors. So you see, this part you should be very clear, because some examiner asking about the history of smoking. Smoke contains nicotine. Nicotine is a potent vasoconstriction. So if there is vasoconstriction in the wound environment, there is possibility of impairment of wound healing because of vasoconstriction. Second is, this nicotine causes platelet aggregation. So there might be some microthrombi in the wound environment, which may impair wound healing. Next is, this nicotine impairs maturation of collagen. Initially, when the wound heals, the initial collagen laid down is type 1 collagen, and it matures to type 3 collagen. So this maturation of collagen will be impaired. Next is, smoke contains carbon monoxide. And this, in chronic smoker, there is increased carboxyhemoglobin in blood. And this carboxyhemoglobin shifts the oxyhemoglobinization curve to the left. So this impairs tissue oxygenation. And this tissue hypoxia may impair wound healing. So you are always mentioning smoking history is important, but these are the basic mechanism how smoking can impair wound healing and subsequent outcome in hernia patient. Okay, so you can proceed with the examination.
Now, this part is also important when you are dealing with certain cases, like for example, you're dealing with a non-healing ulcer, where you're trying to plan some kind of a coverage in the form of a flap or something. So all these points are going to be very important there also, right? When you're talking about peripheral vascular disease, again, the same things come up. So these points are very common in number of cases. So you need to study about this smoking, how it affects these patients separately, and keep that in mind, right?
Okay.
Okay, please continue.
Now coming to the examination, in general survey, the patient was conscious, alert, and cooperative with the Karnofsky performance status of 90. Average build, poor nutrition with BMI of 21. Patient was well dehydrated. Gait and facies was normal. Pallor, icterus, edema, clubbing, and sinuses were all absent. Neck veins were not engorged, and neck nodes were not palpable. Pulse rate was 88 per minute regular, and blood pressure was 116 by 70 millimeters of mercury. Respiratory rate was 18 by minute, with respiratory type being abdominothoracic, and temperature was 98.4 degrees Fahrenheit. Now coming to the local examination, which is the examination of bilateral inguinal scrotal region. Inspection was done in standing position. On bilateral side, there was a visible swelling present in the inguinal region. On the right side, it was extending from the inguinal region up to the superficial inguinal, up to the superficial inguinal ring, and on the left side, it was in the inguinal region. On the right side, it was approximately 6 into 6 centimeter, and the left side approximately 4 into 4 centimeter. Shape was globular on either side. Surface appeared smooth. Margins were rounded and well defined on either side. Uh, Expansile impulse was present on either side. Skin over the swelling was normal. Visible peristalsis was absent, and testes could be seen separately from the swelling on either side. Now coming to palpation. The temperature was normal on either side. Tenderness was absent on either side. On the right side, the swelling extended from the inguinal region up to the superficial inguinal ring, and on the left side, it occupied only the inguinal region. On the right side, it was approximately 6 into 6 centimeter size, and left side approximately 4 into 4 centimeter. Shape was globular on either side. Surface was smooth. Margin was well defined and rounded on either side. Consistency was soft and elastic on either side. Expansile impulse on palpation was present on either side. Relation with the pubic tubercle, it was above and medial to the pubic tubercle on either side. It was reducible bilaterally, and deep ring occlusion test was negative on either side. Invagination test was not done. On percussion, there was resonant note over the swelling bilaterally. On auscultation, there were occasional peristaltic sounds heard on the right side. However, no sounds could be heard on the left side. Per rectal examination revealed normal sphincter tone, and no mass could be palpable. The prostate was palpable. It was firm in consistency, enlarged in size. The mucosa was free, and the medial sulcus was obliterated. The tone of the abdominal muscles were good. Systemic examination in the gastrointestinal system, abdomen was soft and non-tender, no organomegaly and no ascites. In the cardiovascular system, S1 first and second heart sounds were audible. There was no murmur. In the respiratory system, there were normal bilateral vesicular breath sounds and no added sounds could be heard. And in the CNS, no focal neurological deficit was there. Now coming to the summary of the case, a 65 years male patient presented with bilateral groin swelling for 3 to 4 months, which appeared spontaneously, was insidious in onset, gradually increased to its present size of 5 into 5 and 3 into 3 centimeter. The swelling reduced on lying down and reappeared on standing, walking, and straining. Patient also gives history of occasional pain over the swellings, dilating in nature, which increases on standing and reduces on lying down. Patient also gives a history of work involving heavy weight lifting as occupational history, and history of lower urinary tract symptoms of nocturia, increased frequency and hesitancy of urine. No history of constipation or period of irreducibility, and severe pain associated with vomiting and obstipation. On local examination, there is a bilateral inguinal swelling on inspection, reaching up to the superficial inguinal ring on right side, and size is 6 into 6 centimeter on the right side and 4 into 4 centimeter on the left side. Globular in shape, smooth in consistency, having rounded margins, with visible cuff impulse bilaterally and no visible peristalsis on either side. On palpation, the swelling is located above and medial to the pubic tubercle on either side, is soft and elastic in consistency, reducible, as a palpatory cuff impulse, and deep ring occlusion test is negative. On rectal examination, the prostate is enlarged bilaterally, is firm in consistency, has a smooth surface, and the mucosa is free. So shall I proceed with the provisional diagnosis? Provisional diagnosis is a case of bilateral reducible incomplete direct inguinal hernia containing gut without any features of complication at present in a 65 years gentleman with features of prostatism. According to HS classification, it's bilaterally, it's primary medial width is 2.
Okay, you mean right PM2 and left PM2? Now, regarding this classification, I think I'll have to say something, because this classification was initially, or I think, it was developed mainly not to be done in the preoperative setting. Because when you are saying, you're commenting about the size of the hernial orifice,
Yes,
is it?
sir.
So the problem is, it is very difficult to assess the size of the hernial orifice. May it be the deep ring, or may it be an area of weakness in the when you are dealing with a direct hernia, right?
Okay.
So it was, that is how it was actually planned, because it is this size can only be commented upon after you have operated on the patient. Anyway, that is mentioned in the international guidelines. Okay. Now, one
Okay.
more thing. In the examination, you have mentioned somewhere that one of the swellings, they extend into the extend up to the superficial ring, whereas the other side it does not. I think such a specific thing is very difficult to make out on examination, especially in case of direct hernias. I think you can just give us the measurement and tell us that it is placed, I mean,
Okay.
in the inguinal region. And when
Okay.
you're going through the examination, you can say that yes, the occlusion test, deepening occlusion test is negative. That's okay. It's
Okay.
very difficult to assess, I mean, whether it is extending up to the superficial ring or not, because in that region, it is in direct hernias, it's usually a bulge
Yes, sir.
bilaterally, isn't it? Fine, that's
Okay,
okay.
sir.
Now, how will you confirm your diagnosis in this
Now,
patient?
before that, Snehashish, the point Dr. Shah raised, you said the swelling is 4 by 4 centimeter on the left side.
Yes, sir.
What is the length of inguinal canal?
Yes, sir.
What is the length of inguinal canal?
So length of inguinal canal is 5 to 6 centimeters, sir.
No,
No, 4 centimeter.
3.8 centimeter.
Okay.
So if the direct hernia is a bulge in the Hasselbalch triangle, it starts medial to the inferior artery.
Okay, bigger, sir.
And
Yes.
a 4 centimeter swelling, it has to be in the superficial ring. Once the patient is standing up and you say swelling is 4 centimeter, the 4 centimeter swelling in the Hasselbalch triangle has to be the extent from region of mid-inguinal point to,
Deep ring to superficial ring.
yeah. So 4 centimeter is area, you cannot say it has not gone to the superficial ring. And it is very difficult to, you said you have not done invagination test. So it is very difficult to make out the size of the superficial inguinal ring. Okay, invasion test was done to assess the size of superficial inguinal ring,
Okay.
and you can easily appreciate that the superficial ring is spatulous or not, which will indicate that the swelling is going beyond the superficial inguinal ring. Okay, I would ask other students to follow. If a bilateral hernia, it is wise to mention this in a tabular form, because otherwise you have to mention everything again in a sentence. It will be very difficult for you to just write in the exam. So if it is a bilateral hernia, you make a table and just give the points. Okay, and the summary is starting now. Don't say 65 years male. We have already made a standard presentation. 65 years gentleman presented with this. Okay, otherwise your presentation is good. Okay, so Dr. Shah has asked you next question.
Now, before that, another thing, if we are dealing with a unilateral hernia, don't forget to mention the opposite side first, that
Yeah.
on this side there is no swelling. Then you proceed to your ipsilateral side. Fine, that is okay. And now we are dealing with a bilateral hernia. So yes, the question stands, how will you confirm your diagnosis?
Sir, the diagnosis of inguinal hernia is a clinical diagnosis. To confirm my diagnosis, I do not need any other investigations as
Now, I
such.
think it is better if you place it like this. Sir, in this patient, let us talk with respect to this patient. Now, in
Okay.
this patient, my diagnosis is clinically very obvious, and
Yes.
it is a clinical diagnosis. Therefore, in this case, I will not need any further aids to confirm my diagnosis.
Yes, sir.
Because in certain other hernias, you may have to get in some investigations done. So, let us talk to you make it a point that in this patient, it is my clinical diagnosis. Fine.
Yes, sir.
Now, what investigations would you like to do to proceed with the treatment?
And if
Sir,
I ask one more question, in some groin hernias, not this patient who has got a classic history of swelling, going down on lying down, there are some situations where there is some patient having a groin pain and he is complaining of swelling, you are not getting the swelling. So what are the situations that you will ask some investigation to confirm the diagnosis of hernia?
Sir,
In
if
which
the
patient has got some groin problem.
So if the patient is complaining of a swelling, but I'm not getting the swelling on examination,
Yes.
and in some patients who are complaining of chronic groin pain, there may be an occult hernia present. So we may need to investigate that
And
patient.
this is more commonly in case of obese patient.
Obese
Patient who are
patient.
very obese patient, may have a swelling, and it's very difficult to appreciate that swelling on clinical examination. So the investigation for confirmed diagnosis of hernia comes up when there is a doubt in diagnosis, patient is obese, and often patient has chronic groin pain. What should be the investigation? What is the preferred investigation for this?
Sir, initial investigation should be USG, but CT is more able to delineate the anatomy than USG.
Yes. Dr. Shah.
Yes, and let me tell you, the maximum number of investigations, that is ultrasound, is advised in patients who come with obscure pain in the inguinal region. So that is the commonest complaint that we have to investigate, and when maybe you don't find anything, you will add an ultrasound to start with, right? So after ultrasound, then only you will think of CT and MRI. I think it's very rarely done. Now, in case you're doing CT, right? So we use a term for that. We may add a contrast. Can you tell us what is that called?
No, sir,
Herniography,
no.
right? So that is done, and you may now, any advantage of doing MRI over CT in such patients who are complaining of an obscure pain in the region? Yeah, because MRI can also pick up certain other things, right? In CT, you will only know about whether the presence of hernia or not. Yes, but for example, things like somewhere a problem arising from the periosteum, osteitis, right? Some problem in the adductor muscles, right? So these things can be picked up by MRI, in addition to what you are looking for. Right. So other causes of pain in the groin is better picked up with MRI than with any other investigation. That is something you have to remember. Okay. Yes.
Okay.
Carry on.
How will you proceed in this patient?
In this patient, yes.
Sir, in this patient, I like to do a USG of KBP region with post-bile residual urine, and to see the status of the bladder, ureter, and kidney status, and also to see the post-bile residual urine, as the patient has already got symptoms of lower urinary tract symptoms. And according to that, I may need to proceed with the uroflowmetry to establish my diagnosis of prostatic enlargement. And other than that, I'll need baseline investigations before I proceed for surgery, baseline blood works and ECG, chest X-ray.
Will you proceed straight away for surgery? You need to have some considerations regarding his prostatic symptoms and the finding on USG.
So first, we will need to address the lower urinary tract symptoms. We'll need to manage it first medically. If it's intractable on medical therapy, then we may need to proceed for surgery for the prostatic symptoms as well.
Okay.
Yes, basically you have to go for an ultrasonography, as you rightly pointed out, KUBP, or you may just go for an ultrasound of the whole abdomen. Nothing wrong with that. So that will tell you about the size of the prostate, right? If there is any intravesical component, not only the size of the prostate, it will also tell you about the bladder, a very important thing. Sometimes we refer to the prostatic size, we find, oh, it's normal or it is marginally increased in size, but we tend to ignore the bladder. You have to look at the bladder wall thickness, whether there is any trabeculation, diverticula. So all these things point towards a bladder outlet obstruction. In that case, you may have a prostate size normal, nothing wrong with that. You may have a fibrous prostate giving rise to these things. So in that case, you need the help of a urologist, right? So the urologist will help you with, as you rightly said, uroflowmetry, and that will possibly point out how far a bladder outlet obstruction is there, and whether this condition can be treated immediately, needs to be treated immediately, or it can wait after the hernia procedure is done. But as a whole, in principle, all outflow obstructions have to be addressed first before you address the hernia. Right? Fine. Yes, Makhunda sir.
Yeah. So you have significant prostatic symptoms, and he already had some trial of medical treatment. Now he is presented to it with gross prostatic symptom with significant residual urine, and he was on medical treatment for prostate for about 6 months. So there is a scenario at the moment. What should be your plan for this patient?
Sir, if the patient is having severe symptoms and is not responding to medical therapy, then we may need to go for surgical excision. Like
What is the standard
so
treatment for?
standard is a transurethral resection of prostate. We'll go for it, and afterwards we can proceed with the hernia surgery.
There are some situations where patient comes to you with more of intractable hernial symptoms, and he has some symptoms of prostatic symptom which is not being getting relieved with medical treatment. So you have to consider the urgency of hernial symptoms versus the prostatic symptoms. So this patient has got reducible hernia on either side.
Yes.
Okay, but he's having pain. Okay, can you explain pain in patient who has got hernia? What are the causes of pain in patient who has got hernia? Is a painless disease basically.
Yes, sir.
Why patient of hernia may have pain?
So usually the pain in hernia is a dull aching in nature due to
Why? What is the mechanism of pain? Why?
So due to the irritation of the peritoneum, sir.
Not irritation. What happens?
So due to the stretching.
Yes.
Of
So
the
it's a parietal peritoneum that is coming up.
Peritoneum, yes, sir.
So patient having hernia may have pain for number of reasons. One reason for pain is this pain can come at the beginning of hernia when the hernia is in evolution. That means patient is standing up, more and more contents are coming down, and hernial sac is getting stressed. That is the reason that this pain get relieved on lying down.
On lying down, yes, sir.
Second cause of pain is?
So if the hernia is getting obstructed, then
before obstruction, even a irreducible hernia may have pain.
Yes.
Because in irreducible hernia, some more content may come up. There may be adhesions in the hernial sac. So irreducibility may be one cause of pain. Next is pain of obstruction. What is the characteristics of pain in obstructed hernia?
So in obstructed hernia, the pain is initially colicky in nature.
Yes.
As the loop of the bowel is obstructed, and
So
it leads
in
to
obstructed hernia, the hernia becomes irreducible.
Yes, sir.
Irreducible, and patient has got colicky pain initially to the site of hernia. Subsequently, patient may have colicky pain in the abdomen also.
Yes.
And next cause of pain is strangulated hernia.
Strangulation, sir.
How does the strangulated hernia pain differs from obstructed hernia pain?
The strangulated hernia pain, it's severe in nature, and it's continuous. In colicky, it's a continuous pain.
Colicky pain is replaced by dull, aching, constant, continuous pain. There is another cause of pain in hernia. What is that hernia called as?
Incarcerated.
No, incarcerated is a different situation. It is the inflamed hernia. The contents of hernia may get inflamed. So patient will have pain, they will have tenderness in the local site. It's not strangulation, inflammation of the hernial contents. So these are the different causes of pain in patient who has got hernia. Okay? Yes, Dr. Shah.
And let us remember that small hernias are more painful than large hernias, usually, right? So when the hernia is starting out, so then it usually causes pain. When it is reached about a certain size, then the pain usually subsides.
Yes, because the staging has occurred.
And then again, you will have pain when the hernia gets complicated, right? So small hernias, we should remember, are more painful than large hernias, right? Okay. Now, I'm going slightly outside the thing. Now, why has this patient got a hernia in the first place?
Sir, so patient has a long-standing history of straining factors. Patient was working in a garment shop and a history of heavy weight lifting.
In other words, I'm trying to find out the etiological points, right?
Yes. Yes, sir.
Yes.
So the patient has a long
etiological factors.
What happens in lifting weight? How it can cause hernia? What happens in lifting weight?
So the tone of the lower abdominal muscles increases on a.
So what happens? What happens when you try to lift a weight? What happens to intra-abdominal pressure?
So the intra-abdominal pressure increases. So does the tone of the lower
chronically, when here is lifting a heavy weight, this causes increased internal pressure, which is a chronic situation because he's in this profession. That is one reason. Number two.
So number two, patient is also having some bladder outlet obstruction due to prostatic enlargement.
Yes. Again,
so that is also
this causes strain.
Increase in yes, sir.
And
And patient is also a smoker, sir. Although
Yes.
patient does not give any history of cough or COPD, but patient is a smoker for 30 years,
Yes.
uh, which uh, which can which will lead to increase in intra-abdominal pressure due to increased lung volumes.
Now, have you asked about the family history?
He has. He said no such
Yes, sir.
no significant family history.
Now, do you have anything to say regarding hernias in the family?
So usually hernia is in hernia's family history is not so significant.
Are there a situation where you can find patients who has got a family having almost all members having the hernia? Any condition?
So if there if the patient is having some collagen vascular disease, then it can be there can be family history can be present.
Collagen
No,
disease. Any example?
For Marfan syndrome and Ehlers-Danlos syndrome.
Yes, Ehlers-Danlos syndrome is one situation where there is a lot of immature collagen forming in the body. So there is a weakness of the tissues.
Yes, sir.
now, if you go through the international guidelines, they have mentioned that first-degree relatives having hernia makes an individual more prone to hernia, especially inguinal hernia, right? That is one thing we'll have to note. Yes. Uh, then certain other things, say for example, uh, here, of course, the patient is having prostatic symptoms, but any patient who has undergone a prostatic operation, more so if it is an open prostatic surgery, which I mean don't occur nowadays. Most of the things are done endoscopically. So such patients are also having an increased history, or you find that there are more chances. Now, have you? I think you have commented on BMI.
Huh.
Yes.
Why do you say patient is poor nutrition? I forgot to ask this question. Why do you say patient has poor nutrition? You said BMI is 21.09. How can it be poor
Yes, sir.
nutrition? Do you think patient is having poor nutrition?
Sir,
It's in the normal range. You can say average.
yes, sir.
If
Yes,
you
sir.
say BMI
Yes,
of 21,
more
you
than
cannot
20.
say,
More than
yeah,
20,
Yes,
isn't it? Yeah.
yeah.
yes, sir.
Now, which patients are prone to hernia? If you consider BMI, that is what I mean.
Sir, obese patients are more prone to hernia, sir.
No, yes, you are correct.
And lean
In
and
addition to that,
like extreme,
in both
very
extremes,
lean and thin, very
yes,
lean and thin
both
people are also
Both
extremes,
extreme. Both extremes.
both extremes are more prone to hernia, right?
Okay. Another
Now,
point. You said Karnowski was 90. Why? What do you mean by 90 Karnowski? Although it is applied for the malignant patient, but now you are applying it to all surgical patients for their fitness. Karnowski
Yes, sir.
90 is what?
Patient is having like little difficulty in
Yes, minor
doing daily work.
symptoms and signs of the
Minor
disease.
symptoms. Yes,
This
sir.
patient having swelling on both groin, having pain, having
Yes, sir.
associated prostatic symptoms, I will consider this patient having major symptoms. Okay, so it is better to put this as 80. Okay, 80 is patient can take his normal activities and he has major symptoms and signs of the disease. Okay, patient has got just a small swelling, not bothered about the swelling going on. You can say 90. But patient having bilateral swelling, pain over the swelling, which requires rest, it should be safely 80. Keep in mind what you are saying, that particular situation. Okay, fine. Yes, Dr. Shah.
yes. Now, previously, or even nowadays, we find that it is mentioned that hernia is just a local finding or a local presentation of a systemic disease. Can you comment on this statement? As I said, why is this patient having a hernia? You have mentioned some points. You are very correct. Now, if I say that hernia is a local finding in a systemic disease, and you are asked to comment on this, I'm trying to point out regarding collagen disorders. Now, it has been seen that in hernia, for example, matrix metalloproteinase 2 is found to be increased in hernia patients, right? More so if it is in case of a hernia like this, the one we are discussing, bilateral inguinal hernias. Now, what is this? It is referred to as MM2. Now, MM2, now there are a number of MMs, right? Now, what are these? Any idea?
No,
No.
no, sir.
Yes, just a few words on this. These are actually proteinases which affect the collagen metabolism, right? Now, it has been proved beyond doubt that in case of bilateral hernias, we find that this level is almost double what you find in indirect, sorry, in bilateral direct hernias, it's almost double of what we find in indirect hernias. And in indirect hernias, it is 1.5 times higher than what we find in normal individuals, right? So that is the reason why they say there is a altered collagen metabolism is the key factor. That is one view actually in case of bilateral direct hernias. That is why, because we find certain patients getting bilateral direct hernias, whereas others who are not, even they have in a very, even if you find them in a very poor physical condition, but still they don't have hernias, right? So collagen metabolism is something you will be asked in the exams, right? Just try and go through it and how this altered collagen metabolism tends to affect the hernia formation, right? The ratio of 1:3 collagen is actually altered because collagen 1 is basically the main collagen that is found in the body, accounts for about 80 to 90%. But in such patients, you find the 3% is much higher, right? So that is why it is termed to be a systemic disease of altered collagen metabolism. Okay, fine. Yes.
And if you take the systemic symptoms, you say nutrition can cause hernia, then other general factors like chronic staining factors. They're all part of a associated disease leading to hernia.
Yes.
Okay.
Fine.
So
Okay. Now, how would you like? Yes, you have done all your investigations. Now, how would you like to help this patient?
Sir,
Do you
sir,
think
I
all
would like,
patients? Now, just a general question. Do you think all inguinal hernia patients need surgery?
yes, sir. All patients need to be operated because otherwise it may lead to complications, sir.
No, I think the answer should be slightly different. The answer should be like this: that all symptomatic patients who have hernia, who have been found to have a hernia on examination, need to be addressed by surgery, of course. Right? Fine. Now, if you have certain other patients who have a hernia, a small hernia, maybe you found it accidentally, or maybe even the patient has drawn your attention to it, you can get them into what is called WW therapy. What is that? Waitful watching. Now, what is waitful watching? You can let the patient know that he has a hernia, talk to him, discuss with him that these are the complications, but I think your hernia is quite small and you are a person who is aware of this thing, so we can wait. But then you should also inform the patient that those patients who have a small hernia, remember 70% at the end of say around 7 years, they need to get operated because they either have the pain increases or they have certain complications. So most patients in this group will need operation. Maybe they will not need it now. So when we are talking of the whole spectrum of inguinal hernias, so remember that all patients don't need to do it, but most patients do. Okay, let us come down to this patient.
particularly patient having a direct hernia with wide neck. They are the patients where the watchful waiting may be more desirable. Okay, it's a small indirect hernia may be more symptomatic. There is chance of complications higher. If you have a direct hernia with wide neck, and consider a patient who is unfit for surgery for some medical reasons. In that case, also you can have a watchful watching.
Okay, let us come down to our patient.
Yeah.
How would you like to help this patient?
Sir, I would first like to start the patient on medical therapy for the prosthetic
Better
symptoms.
answer, Shreyansh, it would be that I'll seek an opinion of a urologist. Okay, as a general surgeon, you cannot decide about the definite treatment of prosthetic enlargement. So here it will be better to say, sir, I will seek an opinion of urologist as to the optimal treatment for the prosthetic symptoms. If the opinion is that yes, he can continue medical treatment, I will continue and consider my surgical treatment. If the urologist says patient needs a surgery for prostate on priority basis, what should be your plan? We are discussing on that point. If he does not require surgery for prostate, he is a medical and he go for surgery. What I'm saying is he needs surgery for prostate on priority basis. What should be your plan?
So So nowadays the gold standard is transurethral resection of prostate.
And
So we will have to proceed with that, and in the short term follow up, we can proceed with the hernia surgery once the prostatic symptoms are
that
relieved.
means you want to have the prostate surgery first, discharge him home, and then come back for hernia surgery.
Uh,
That is your plan?
yes, sir.
But he was more concerned about his hernia. Can these two surgery be combined?
Sir, we can do, sir, if we like extend the inguinal incision medially, and from that we can do a
No.
suprapelvic
Prostate, you are
open
talking of
prostatic
TURP. Prostate, you are talking of TURP.
Yes, sir.
What I'm saying is there a situation that you can consider doing TURP and bilateral hernia surgery in same sitting?
Sir, I'm not aware, sir.
Okay. So you say it's a stage surgery. Why? What is your point in favor of doing a stage surgery?
So because the symptoms of prostatism is one of the causes or the risk factor for the hernia. So unless the primary pathology is addressed, there may be chance of recurrence of the hernia, even if we do surgery.
Okay.
And
In fact, there is no consensus statement saying that this has to be staged or this cannot be done in same sitting. One point against is if you do a TURP surgery, patient has given a lot of bladder wash. There is some hypervolemia. Okay, so some people will say that this can be done in the same sitting, provided patient is otherwise fit for the surgery. So you can carry on the TURP followed by bilateral laparoscopic. What's the plan? You want to open surgery or laparoscopic surgery in this patient?
sir, laparoscopic surgery, sir.
Okay. Yes, Dr. Shah, your opinion.
Yes. Now, since you have said that these hernias are of two different sizes, right? One is
Yes.
slightly small, the other is maybe slightly large. So
Yes,
in case you are doing laparoscopic surgery, very good. In case you consider it to be an open surgery, in that case, which one would you do first?
sir,
Right side or left side?
the larger one, right side, I'll do first.
No, it's nothing like that. We can do both at the same time.
Both
Right?
are different.
Yes, yes. Whether it is
Yes,
open surgery or laparoscopic surgery, obviously,
yes,
laparoscopic, obviously, you can do both, no problem. In open surgery also, you can do both at the same time. There's nothing wrong
both
with
at
it.
the same time.
So previously
Okay.
we had those debates, which one to be done first, the larger one or which is more symptomatic and all that. Anyway, we have recommendations say that you can do it simultaneously on the same table, nothing wrong with it if you are doing open surgery. And if you're doing laparoscopic surgery, there is no problem at all. If you are doing transperitoneal, then you can see both hernias together, fine. And if you're doing TEP, then also you can see both hernias together. Maybe you need slightly more dissection on either side, no problem. So obviously you can do both the surgeries simultaneously, right? Since since you have chosen laparoscopic surgery, which one will you choose, TAP or TEPP, and why?
So there is no difference as such in with respect to both of them, but with respect to outcome, as like if the surgical expertise is there for both of them.
Exactly, that should be the answer. So it depends on the surgeon and how expert is he in whichever type he wants to do. So there is nothing to choose between the two, because in
Yes.
both cases we will be putting large meshes which are going to overlap on either side. Fine. So that is a good answer. Okay. Now, if you come down to the intricacies of the surgery, what mesh will you use? How big is going to be?
Sir, we'll use a proline mesh, sir, and it will be 15 by
The
12
answer should
millimeters.
be we'll use a
15 by 12
polypropylene mesh.
polypropylene mesh, yes,
Okay, fine.
and
We
15
will
by
use a
12 centimeters
polypropylene mesh. Yes, on either side. That means we are
on
going to
either side.
use two meshes.
Two meshes, yes, sir.
What will be the size of the mesh?
So 15 into 12 centimeters. The
15 into 12 centimeters on either side,
on either
right?
side.
Yes.
Yes.
You want to comment anything about the midline? Is there going to be any overlap?
Uh, yes, sir. We need to have a 2 centimeter overlap, sir.
Not 2 centimeter, maybe slightly more, about 1/3 overlap, right, in
Okay.
the center, right?
Okay.
What will be the extent of your dissection?
So laterally, we'll have to extend till the anterior superior iliac spine, and medially we'll
No, medially it's bilateral, so there's no question of medially. So
okay,
upper
sir.
and below?
Upper and below we'll extend we'll extend 2
Now,
to
you
3
said,
centimeter beyond the deep ring.
hold on, you said 15 by 12. Which side is 15 and which side is 12?
So the transverse is 15 and the longitudinal is 12.
Up and down is going to be 12. Okay, so up is not very important. You'll have to just go behind the peritoneum. Down, how far will you go?
So down will go beyond the pubic symphysis. Like
That is retropubic, laterally.
retropubic space.
Laterally.
Laterally, he has mentioned anterior iliac spine. Below, how far you will go?
So below
How
will
far
go,
you will retract the peritoneum while you are operating? You'll have to retract the peritoneum, isn't it? Say, suppose you are doing a TEP. How far will that retraction go?
so we'll go beyond the pubic symphysis in the retropubic space.
Yes.
Definitely. That is, you're talking in the midline. And if you go laterally,
What is the ligament you trace laterally from peritoneal point of view, laparoscopic view? What is that ligament you need to expose?
So Cooper's ligament will
Yes.
expose.
Yes.
you will expose
And
the
when you
Cooper's
reflect the
ligament.
peritoneum, how far you reflect the peritoneum towards the abdomen? What is the guide? Because the idea is not to curl the mesh. Mesh should sit comfortably. So you need to strip up the peritoneum from the posterior abdominal wall in the pelvic wall. So at what point you will feel that he has got adequate area for mesh placement as you trace from the deep ring upward?
So from the deep ring upward, we'll need 2 to 3 centimeter, like above, we'll have to
2
dissect from the
centimeters is
deep
too
ring.
less. 2 centimeters is not enough. What is
4
the guide? You don't always measure, but you find the vas difference and the testicular vessels. To the point where the vas turns medially,
Yes.
that is the point
That is the point where you will stop.
yeah.
No further dissection you need to do, because if
So
you
it will vary. It can be 5 centimeter, it can be 4 centimeter. It's not 2 centimeter. 2 is too less.
Okay.
So thing is, as Dr. Makanda was saying, the lower edge of the mesh should not get curled inwards or outwards. It should lie flat, and the peritoneum should go and fall on the mesh. So this is the basic idea. So if it gets curled, then the peritoneum tends to roll up the mesh, right? So that is very important. The same thing will happen laterally also. Make sure that the mesh lies flat on either side and with a good overlap of at least, say, 2 to 3 centimeters overlap. Now,
What do you feel? Fix or no
you
fix?
want to fix the mesh?
Sir, we can, sir, in
What do you
TEP there
do?
is,
What is your practice, your unit practice?
sir, here we usually practice, like in TEP, we usually fix only one with the Cooper's ligament and rest we do not fix.
Yeah.
And in TEP, we are fixing, sir, with tackers.
What is the recommendation?
In TEP, sir. Sir, in TEP, there is no need to fix the mesh with any structure. And in TAP, a single fixation with Cooper's ligament is.
No, what are the recommendations?
Sir, not
And because that is something you'll have to know. Now, the recommendations are very clear. They say in a normal sized hernia or a small hernia, fixation is just not necessary. Number one. Number two, that means in which cases are you going to fix? Yes, the ones where you have a large direct hernias. There, you have to fix the mesh whether you are doing whatever operation you are doing, TEP or TAPP. Now the question is why? Why do we need to fix the mesh in large, the ones if in our patient, for example, where you have large direct hernias? Why do you need to fix the mesh?
So
Because you see, about 20 years back, we were doing, say, for example, incisional hernias, and we were making it tension free in the sense that we did not even close the gap in case of incisional hernias. Now the thing has changed. Now it is mandatory that you will have to close the defect, right? That is why in certain cases we make it plus,
yes,
right? Now, inguinal hernia is possibly the only hernia where the defect is not directly closed because it is just not possible. Right? Fine. But in cases like this where you have large defects, large direct hernias, right? The defect is almost impossible to close. How will you close the defect? It's not possible. Right? In these cases, if you don't close the defect, if you don't fix the mesh tends to bulge out. Right? Just as there is a bulge, this mesh also progressively, you'll find after a few years, you'll find the mesh also bulges out. So that is why in large direct defects, the recommendations say that you will have to fix the mesh at multiple points, right? And where will you do it? How will you do it? That is your problem. You will have to deal with it according to the patient. So that is the only exception. That is in case of large direct hernias, you need to fix the mesh. Otherwise, you can go without fixation. Correct?
Yes.
Okay, fine.
Last question from my side. What is the boundary of Fouchard orifice?
So the myopectineal orifice of Fouchard is bounded, sir, laterally by the iliopsoas muscle, medially by the lateral border of the rectus abdominis muscle, and
Sheath, not muscle, sheath.
yes, sir,
Rectus sheath.
lateral border of the rectus sheath, inferiorly by the pecten pubis, and superiorly by the conjoint tendon, sir.
Pecten pubis covered by Cooper's ligament. That is the
Cooper's
boundary.
Yes.
What is the importance of this orifice?
Sir, all groin hernias, that is direct hernias, indirect hernias, and femoral hernias occur through this.
So we must be knowing all the boundaries of orifice of Fouchard.
Yes.
Yeah, Dr. Shah, I think we have covered almost.
Yes, yes. Lastly, that at least we'll talk about two most important complications.
Sir, in laparoscopic surgery, sir.
Irrespective of surgery. I mean,
Okay, sir.
two most important.
Sir, hemorrhage and seroma formation, sir.
Hey, no. I mean, when I'm asking you two most important, it can't be anything to do with hemorrhage and all that. So I would like an answer like pain and recurrence.
Yes, sir. Yes, sir.
These two are the most important complications that I would like to talk about, or any person regarding hernia. Yes. Now tell us. You were telling something about laparoscopy and all that. So, few comments from your side regarding pain.
Sir, in pain, sir, following open surgery, the incidence of chronic groin pain is a little bit more than in laparoscopic surgery. That's why, like, and in laparoscopic surgery also we
find chronic pain following
chronic groin pain. When you say this pain, chronic groin pain.
So following hernia surgery, if there is pain occurring more than 8 to 12 weeks even after surgery in the groin,
in spite of some analgesics.
In spite of
you can stamp it as 3 months, not 8 to 12.
Okay.
Make it 3 months. Yes.
Okay. 3 months.
Most people agree that anything which is persisting more than 3 months is chronic pain, and the same apply to hernia also.
Okay.
So this is referred to as pain. Now this is gradually coming up to be the most important complication, right? It is overtaken recurrence also. Approximately, what is the incidence? You have rightly pointed out that it is more common with open surgery and less common with laparoscopic surgery. Around 10 to 12%.
Okay.
So what steps will you take to make sure that the patient you are operating on does not suffer from pain? Say, for example, if you're doing open surgery.
Sir, in open surgery, we'll have to be nerve-minded, sir. Like while fixation of the mesh, we'll have to make sure that we are not taking the nerve in between the bites for the fixation of the mesh. That may need to nerve
usually is in danger.
So ilioinguinal nerve, sir.
Ilioinguinal nerve. So this nerve usually you can see it almost in all operations.
Yes,
so make sure that this nerve is identified and set aside. You don't pick up it. You don't pick up this nerve in your bites. Apart from that, what else can you do?
Sir,
why don't you fix the mesh laterally? What nerve comes there? Why don't you fix the mesh laterally? Which nerve comes laterally?
Sir, in open surgery, sir.
Even in laparoscopy?
Sir, in laparoscopic surgery, so laterally there will be lateral femoral cutaneous nerve and genitofemoral nerve, femoral branch. So those
so should not attack on that side. Yes.
Yes, there are other nerves also. Femoral nerve is also there laterally. There are plenty of nerves. Yes, as you are rightly pointed out, these two nerves are the most endangered. Now, another thing I would like to point out in open surgery, nowadays they are advising that while you're fixing the mesh in medially, make sure that you are using delayed absorbable sutures and not polypropylene. You can use PDS, right? And make sure that you don't pick up any of those perforating neurovascular bundles. They're also, those bundles are also accompanied by small nerves. When you're fixing it to the conjoint tendon, make sure you're using delayed absorption. Number one. Number two, make sure that you don't pick up the periosteum on the
Yes.
While fixing to the
pubic
pubic tubercle. Yes.
Yes.
Previous stitching was stitched with the periosteum of the
Yes.
pubic tubercle. It's not necessary. It causes more chronic joint pain.
Yes, you have to pick up epineuritic tissue in and around the pubic tubercle, not the periosteum. That is something you have to make sure. So
Yes.
these steps will help you in preventing chronic pain,
Chronic pain.
mainly in the operating setting, mainly in the open surgery setting, and as you rightly said, in the laparoscopy setting, you should not. We have already discussed that we will not fix the mesh.
Yes.
So if we don't fix, the injury to the nerve does not arise. And one more thing, when you're dissecting laterally, make sure you don't bare the nerves. Let the nerves not come into contact with the mesh directly. There should be some areolar tissue out there which will cover the nerves, right? So don't try to see the nerves while you're doing laparoscopic surgery. That is the most important thing. If you have seen the nerves, that means that areolar tissue on the nerves has been removed by dissection, right? Fine.
Okay. Someone has asked why that TURP and hernioplasty can be done simultaneously. We have answered that. If you have the expertise and patient is otherwise medically fit, both the procedure can be combined in the same sitting. Okay. Dr. Shah, thank you.
Okay. Thank you, everybody.
Thank you.
Thank you, sir. Thank you, sir.